I'm Matt Yapro, as I think most of you know, and I'm happy here to be with Ahmed Sadildan, who is going to be animating this session with me. And could I ask that
response. Yes, no, or abstain. Okay, so we have majority saying yes, as expected. Second, chemotherapy or hormonal treatment induced amenorrhea. Okay. Okay, as expected. Seventh question is, endocrine treatment is a valid option in hormone-positive tumors and should not be given in hormone-negative tumors. Please vote. Okay. 14.7% said no.
Ahmed, I think that, for somebody who vote for number 2 to tell us why he's doing this.
In 30 seconds.
Somebody give us some explanation, please.
Okay.
This is not fair.
All right. We expected 100, by the way, but if anyone had a strong reason to say 2, please raise your hand. Okay, we move to the second question. Other than ovarian ablation, concurrent hormonal treatment, and chemotherapy should be discouraged. Yes, no, or abstain. Okay, possibly a little bit than expected, abstained actually from the answer. Next question. In locally advanced and metastatic breast cancer, concurrent AIs and chemotherapy may be used in the context of a clinical trial. Please vote. Clinical trials. Okay, 11.8%. They believe that it should not be even used in a clinical trial.
Dear Professor Ahmed Saaduddin, I'm not aware of any clinical trial rather than everolimus with letrozole or everolimus with exemestane that we can conclude any clinical guidelines to use aromatase inhibitor, which is in between brackets a hormonal treatment for hormonal responsive postmenopausal tumor with chemotherapy in metastatic setting.
I think Professor Heba, what the question is trying to say, if there is a clinical trial, would you include patients in it? That is, I think, the theme of the question. Okay, next question. Adjuvant tamoxifen should be started after the end of post-operative breast irradiation and not be given concurrently with radiotherapy. Tamoxifen concurrent with radiation therapy. Please vote.
So here we have clearly a split vote. If you read the literature, there are differing opinions. My understanding is that it can be given concurrently, but obviously there's half of the room that doesn't accept this. Number 11, adjuvant LHRH analog and or aromatase inhibitors can be used with postoperative breast irradiation if clinically indicated. This is concomitant treatment of these entities. You voted half-half against tamoxifen. This is absolutely remarkable, and I think we will need to have this discussion at the next meeting. Next one. This is in 4 parts. So if you look here in the middle, you will see first the 4 parts that are going to come. The first part is in postmenopausal women, when neoadjuvant treatment is considered, endocrine treatment is the preferred treatment option in patients with luminal A disease. Yes, no, abstain. There's neoadjuvant treatment for endocrine responsive disease. Okay. Second part of the question, same question. Postmenopausal women, when neoadjuvant treatment is considered, the preferred treatment option is in high expression of hormone receptor cases. Yes, no, abstain. Okay, you're consistent. Third part, same question, but now all hormonal receptor positive cases. So about half of you, a little bit more than half of you indicate that no, it's not true for all hormone receptor positive cases. And finally, fourth option, same question. Is this a preferred option in hormone receptor positive lobular carcinoma? I remind that we had a discussion yesterday about lobular carcinoma. Okay, very good. So we will move to the next question. Question number 12. This is again one question which is separated in 4 parts. In postmenopausal women, when neoadjuvant treatment is considered, I should have moved to 13. Okay. You have it 13, everyone? There we go. 13. In postmenopausal women, neoadjuvant AIs are preferred over tamoxifen because of better response rates. Yes, no, abstain. We have enough evidence to say that it should be an AI and not tamoxifen. Okay. 14. In premenopausal women, neoadjuvant endocrine therapy could be used in, and we have 2 parts. First part, in all hormone receptor positive cases. Yes, no, abstain. Second part. In premenopausal women, neoadjuvant endocrine therapy could be used in selected highly endocrine responsive tumors with low proliferative index. Another way of not saying luminal A. Excellent. Number 15. So number 15 is in 4 different parts. In premenopausal hormone receptor positive breast cancer, the standard adjuvant hormonal treatment for patients without indication for LHRH analogs should be. Okay, so this is those that are considered without indication for LHRH analogs. And then the first choice is tamoxifen for 5 years a choice? Yes, no, abstain. Okay. The second question, do we extend tamoxifen to 10 years in all cases? No. I think that Eric Weiner was heard. Third one, option is tamoxifen for 10 years in patients with high risk factors. Okay, and finally, the fourth option, tamoxifen for 5 years, followed by AIs for 5 years if in the meanwhile the patient became postmenopausal. Okay. Okay, now we change speakers, trying not to fall from the podium.
Question number 16 now. In the adjuvant setting of premenopausal hormone-positive cancers, ovarian suppression should be added to tamoxifen. Again, a question of 3 parts. The first one is in all patients, yes, no, or abstain. Okay, expected. The second part is in patients less than 35 years of age. The subgroup analysis. Okay. The third is in patients with high risk factors. Okay. So we all were listening to Professor Eric Weiner. Question number 17. In the adjuvant setting of premenopausal hormone-positive cancers, ovarian suppression plus exemestane this time is preferred in high-risk patients. Yes, no, or abstain. Please vote. All right. So we have almost 2/3 to 1/3. Question number 18. Recommended approach of ovarian suppression is, and this is a question of 3 parts you can see in the middle. The first one is LHRH analog. Please vote. Okay, high percentage. Let's see, radiotherapy to ovaries. Okay, it's not popular apparently. And third option is bilateral surgical oophorectomy. Yes, we'll wait for the vote and give you the... Okay, again, more than half did not. Okay, 30 seconds, please.
Yes, I think there is an economical issue here, especially for some countries who cannot afford for LHRH agonist as a routine.
Yeah.
So this could be divided into when this could be afforded or not.
Point very well taken, absolutely true. Next question. Now, the duration of LHRH analog, when considered to be administered with tamoxifen, should be, and there is 3 parts to this question: 2 to 3 years. Okay, so almost 38% said yes. Now, the second would be 5 years as an option. Okay, so almost 2/3, about 60%, and the third option for debate will be as long as patient is on tamoxifen and is still premenopausal. Yes.
Yes. How could you define that it's still premenopausal if the patient is treated by LHRH analogs and tamoxifen?
Very good point. Yeah, I think, let's say the menstruation is still coming. It's point well taken. And I think this explains why we have various, almost third in each option. Okay, so most of us, we're talking about 2 to 3 years versus 5 years. More in 5 years duration. Question number 20. Again, 3 parts.
Excuse me, Dr. Ahmed.
Yes.
Can we just modify the phrasing of the question such that we are talking about women below the age of 40, for instance? Okay? In women below the age of 40, how far you should keep your patient under tamoxifen? That will be more viable for decision making for the colleagues.
Okay. Maybe we can consider this later on.
This needs to be discussed in the text.
Yeah, we will address this in the text of this discussion. Yeah. So question number 20, in the premenopausal hormone-positive adjuvant setting with contraindication to tamoxifen, the recommended management is, the first option is ovarian ablation only. Please vote.
Or suppression.
Ovarian, suppression with LHRH. Yeah, this is... okay, so 52% majority said no. The second choice is ovarian ablation or suppression with aromatase inhibitors. Okay, majority said yes. And the last choice would be no hormonal treatment. Please vote. Dial change now.
Okay, very good. You notice that there was one question which was clearly very difficult, and I'm happy that Joseph Likorov raised the hand and say, what's this? Sometimes in these questions there are internal controls, and the idea was to have 99% abstentions because the question was clearly impossible. We failed. Question number 21. Number 21. In premenopausal women under adjuvant endocrine therapy seeking desiring pregnancy, planned discontinuation of endocrine therapy to allow pregnancy is a possible strategy. Yes, no, abstain. Yes, 84% of you vote in favor. Just a little comment. 5 years ago on the French-Swiss television, there was a heated debate about all of this, with some distinguished colleagues sustaining that a woman should never be pregnant after having had the breast cancer. I couldn't believe it. Yes?
To rephrase again, we need to put some sort of minimal duration, because interruption after 6 months or interruption after 4.5 years.
No, we are not asking this question right now, but you are right. This should be discussed. But the question was, is this actually something that is acceptable at all? And I think everyone is very happy that the women's desire, with all the data that is available to us, can be sustained when the woman so wants. And here is another question which goes along with the suggestion that you just made. If endocrine therapy is stopped after 3 years, only in order to allow pregnancy, should it be resumed after the pregnancy? Yes, no, abstain. Obviously, there are no studies. Question number 23. In patients with HER2 positive, hormone receptor positive disease, endocrine therapy, when never considered, either in adjuvant, neoadjuvant, metastatic settings, should be combined with an anti-HER2 treatment. Yes, no, abstain. Okay. Now we go to question 24, and you will have the same type of question for the in another option. The first one is in postmenopausal women, and you can see there are 7 options here. The recommended adjuvant endocrine therapy is, and you can vote for several of these options, so one doesn't exclude the other. So, who would say that a reasonable option is aromatase inhibitors for 5 years?
Because reasonable and recommended don't mean the same thing. Recommended
Yes,
means it's your preferred option. Reasonable means it's one of many preferred options. And that's quite important for 7 questions.
Yes, I think that we can take it both ways. And in another question I did correct. I didn't correct on this.